as pain medicine physicians, we have the same biases as the general population. We need to be aware of the racial disparities that exist. Across several studies, we see that Black patients get less spinal cord stimulation compared to white patients, less regional anesthesia compared to white patients, less opioids for acute cases compared to case-matched white patients. We need to be aware of our own biases and the disparities in the healthcare system to do better.
Hello, my name is Jonathan Goree. I am an associate professor at the University of Arkansas for Medical Sciences, where I'm also the director of the Chronic Pain Division and the co-chair of the Opioid Stewardship Program.
My name is Dr. Natalie Strand. I'm one of the authors of Racism in Pain Medicine, We Can and Should Do More. This will be published in the Mayo Clinic Proceedings. In this article, we discuss racism in pain medicine, racism at large, and we propose an inside-out approach of what we can do within our field that can be applied to other fields to be anti-racist.
In this article, really got together with a few of my colleagues and honestly my friends that I really respect in the field of chronic pain. And we had an open conversation that we wanted to have with not only the pain community, but with medicine in general about some issues that we've seen in chronic pain care, including inequity in the treatment of chronic pain. That includes the distribution of opioids. That also includes the distribution or the recommendation for interventional therapies that we all believe in and that we offer every single day.
We look at the ability to change biases. We highlight that biases exist. There is hard data that biases exist, but we also show that these biases can change. Once we normalize and acknowledge these biases, there are specific things we can do to try to remove them. We propose doing this at the medical education level. Medical education should be anti-racist. We can do this in medical schools, residencies, and fellowship programs. In addition, societies need to be anti-racist. We need to acknowledge the effect of leadership, podium presentations, national presence, and look for any biases that might be present based on a racial basis. Industry also needs to be anti-racist. Industry can have a huge impact on academic promotion. Who's a private investigator for the study? Who gets access to these new technologies first? Who is invited to train? Who's invited to be faculty? All of this matters in the academic and private practice world. So again, we propose an inside-out approach, medical education, societies, industry, and medicine as a whole. As pain medicine physicians, we must be deeply aware of how this can influence our practice. We don't want to treat patients differently based on race, gender. We want everybody to have equal access to healthcare, equal access to pain medicine, equal access to our procedures. And we want to serve as an example for medicine as a whole.
In this manuscript, we also discuss solutions, ways that we can make our chronic pain treatments, our chronic pain diagnoses, and our chronic pain therapies more equitable, really to improve care for all of our patients. That includes diversifying our field, that includes changing the way that we do research, and that also changes the way that we evaluate and have conversations with patients.
Our primary clinical goal as pain physicians is to improve the quality of life for our patients. Patients should never receive suboptimal care because of their race, and pain medicine should set an example to other specialties.
I think this will do a lot, not only for the providers in our field, but also for patients. But let me start with patients. I think that this conversation, or my goal, or our goal, is really for this discussion to bring about a larger conversation in our fields and to really begin to have honest discourse about whether our therapies are equitable and to normalize conversations on a microscopic level in individual clinics so that trainees, so that nurses and other physicians and nurse practitioners can have conversations in the clinic about the care that they're providing and whether things like implicit bias or microaggressions or other are creeping in and causing that care to possibly be subpar for some individuals. Our goal is to holistically improve care for everyone because we truly believe that equitable care is outstanding care. Lastly, I think this conversation will improve our physicians because the goal of every physician is to provide the highest standard and highest quality of care that they can.
Acknowledging our own implicit biases and taking steps to break down institutional barriers are the first steps towards eliminating the pervasive racial disparities in healthcare and improving outcomes for our patients. By upholding the principles of just and equitable care and implementing these effective, efficient, and low-cost recommendations, we can better prepare the next generation of pain physicians to improve outcomes and also help end racism in clinical medicine.
We hope that this will add some tools into your armamentarium so that you can ensure that you're providing that. Again, we thank you and we hope that you enjoy our manuscript.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.